likelihood of coronary disease. And in all these groups, the NICE guideline recommends no diagnostic testing. I mean, of course, it's conceivable you'd want to do tests for other reasons. That's possible. But you don't need to, there's no logical reason for doing diagnostic testing in these groups. And we had put together a few years ago now a large cohort of rapid access chest pain clinic patients, about 9,000 from 6 clinics around the country. And when we looked at those categories in which no testing was necessary and applied it to this chest pain clinic cohort, we found 19% non-anginal, 10% very low pretest probability, 14% very high pretest probability, a total of 43% of these patients who need no testing at all for diagnostic purposes. And actually, there's nothing particularly revolutionary about this. This has been applying these kind of principles to diagnostic testing this is all fairly standard fare. But it does remind us that quite commonly patients like this are over-investigated, and over-investigation of these patients is unhelpful. So let's have a look at this graphical representation of the benefits of non-invasive testing. And what we have here is the post-test probability of disease. That's after you've done the test, whether it's positive or negative. And this is some totally hypothetical test with a sensitivity of 75% and a specificity of 80%. So that could be a variety of the tests that we all use. And you can see this is a line of identity. So this is where your start point, if you like, after your clinical assessment. And if the patient's got a positive test here, then the post-test probability of disease goes up a bit, and if it's got a negative test, goes down a bit. But frankly, and obviously, within this very low level of pretest probability, testing hardly shifts your diagnostic judgment. And likewise, at this end, very high, above 90%, testing hardly shifts your diagnostic judgment. And that's the point I was making a bit earlier. But it's in this middle range, but sort of, if you like, between the extremes of diagnostic certainty, that testing is particularly helpful. And if you start at this point of pretest probability and get a positive test, then it really shifts the ante right up to a much higher level, and would then encourage you to investigate the patient further, perhaps. Whereas if these tests are negative in this intermediate range, then again, that's very helpful because it lowers the post-test probability of disease quite substantially. So again, all very conventional, and it's the kind of thing that we've been teaching medical students for a while, but it was those principles that were applied in developing this guideline. Now let's turn to the exercise ECG, because that's been with us for a long, long time. In fact, the first reference to the use of exercise testing I could find goes back to 1942. So that's what, about 80 years ago, 70 years ago. And that was something called the Master Two-Step Test. And then in 1963, the Bruce protocol was developed. And I shouldn't think there are many people, if any, in this room who were at medical school in 1963. So to put that in context then, the Bruce protocol for exercise testing has been with all of us for our entire medical careers, and it's hardwired into everything we do in terms of testing patients with chest pain. And we all recognize these kind of changes that develop in the patient who with ischemia. So the question is, why has the guideline, as I'm sure most of you know, come out and recommended that stress testing shouldn't be used? Well, it wasn't this particular study, which we did in East London nearly 20 years ago now, wasn't actually considered in the guideline for reasons I'll come back to in a minute. But this was a fairly small study of patients who had had acute myocardial infarction and in whom exercise testing was done afterwards. And we were able to follow these patients up for a year and look at their survival. And we found that the event-free survival in patients who had ST depression at low workload, that's what we were looking at, was clearly worse than the survival of patients who had no ST depression. But when you actually looked at this in terms, and so the hazard ratio of a positive test was a 93% excess risk. But if you look at the sensitivity of this test, i.e. the proportion of patients in whom events were correctly identified, it was a rather miserable 50%, which actually is not much better than tossing a coin. So the false negative rate was 50%. That is to say, patients who had a apparently normal test, no ST depression, nevertheless had quite a significant mortality during the first year. And the specificity was only a little bit better. And we concluded, here at the bottom of the slide, that the identification of patients at risk of recurrent ischemic events after AMI is an important management priority, which clearly it is. And in the past, the treadmill stress test has been widely used. That was 1993 passed for this purpose. But our results indicate that it's of limited value for risk stratification. That's what we felt 20 years ago. And more recently, again, another study I was involved with looking at this cohort of patients attending rapid access chest pain clinics. We looked at the incremental value of stress testing for predicting future events. And as I explained right at the beginning of this talk, we believe that incremental value is very important. If a test doesn't add anything to your clinical judgment, then you've got to reconsider its value. And in this test of patients with suspected angina attending chest pain clinics, the blue line shows the added value. This is a rather more sensitive, rather more sophisticated analysis than I showed in the previous slide. These are receiver-operated curves. But the blue line shows the added value of the clinical assessment, and the dotted red line, the added value of exercise testing. And the first thing you'll notice is that exercise testing is quite good at increasing diagnostic value over and above baseline. But it's actually not very good in adding to what you get from your clinical assessment in this group of patients. In fact, these lines are virtually superimposed with one another. And we concluded that in these patients with suspected angina, basic clinical assessment encompasses most of the prognostic value of exercise ECGs. And the limited incremental value, and I think we were being a little conservative of our language here, the limited incremental value of these widely applied tests emphasizes the need for more effective methods of risk stratification in this group. Now, of course, what you're thinking is, well, that's all, that's fine. That's looking at exercise testing for its prognostic value. This guy, and you're absolutely right, and this guideline was actually concentrating on stress testing and other diagnostic tests for their diagnostic value. But there's a whole army of literature out there on the diagnostic value of these tests, all based, as I said at the beginning, around sensitivity and specificity. And what I've done on this slide is listed the 5 high-quality meta-analyses from various journals, which are widely quoted when looking at the diagnostic value of these tests. And as you can see, they're all much of a muchness in the middle of the range in terms of diagnostic value, except for the exercise test, which really performs quite badly compared with these other tests. Its sensitivity is 68%, so that tells you something about the false negative rate, or the rule out, if you want to use it for that purpose. Slightly better on specificity. So why would we want to use, for diagnostic purposes, a test which is less good than all these other tests that are out there? That's the question we've got to ask ourselves. Why would we want to do that? There's a lot of resistance, natural resistance, among clinicians to turn from tests they've been using for all their careers to the newer sort of imaging modalities that we now have available, MR perfusion, marvelous way of looking at ischemia, and of course, as we've heard today, likewise CT angiography. So that's the question, and the guideline group could not ignore this data in making their recommendations. But of course, NICE, as you'll all know, is interested not only in purposes of this guideline, diagnostic value, but also in cost effectiveness. And quite rightly, because if you're spending money on one diagnostic test rather than another, then that's, as we all understand, that's potentially taking money away from other things that are good for patients like hip replacement and so forth. So cost effectiveness is a very important question. And NICE has got some top-rated health economists working for them. I obviously am not a health economist, nor do I know all that much about it, but it was very instructive looking at these people and the way they analysed their cost-effectiveness data. And what they looked at, or what they sought to answer, was these two questions in relation to this guideline. What's the most cost-effective sequence of tests for diagnosing suspected angina, and how is cost-effectiveness of diagnostic testing sequences different for populations with pretest probability of disease? Briefly, that first question just reminds us that quite often patients are subjected to a sequence of diagnostic tests in diagnosing angina. Sometimes that's necessary. And secondly, just to remind you that if you've got a group of people, like a whole load of medical students, for example, then they're going to have a low pretest probability of disease by definition. And so cost effectiveness in that group may be very different from cost effectiveness in elderly patients with chest pain. And so that's the reason they did this. So the purpose of the analysis they undertook was to assess cost effectiveness of 10 different testing sequences, which I'll show you in a minute, in a hypothetical cohort. And they were looking at progression through these sequences based on sensitivity and specificity and indeterminacy of tests in diagnosing coronary disease with reference to invasive angiography. And incidentally, in doing this analysis, they allowed for the fact, as we heard in a previous talk, that coronary angiography doesn't always get it right. And the number of patients progressing through a sequence was determined by the prevalence of coronary disease in the hypothetical cohort. And prevalence, as is traditional in these things, was used as a substitute for pretest probability. So here are the sequences that they looked at, the model diagnostic strategies, first test, second test, third test, and they looked at progression from exercise testing through functional imaging to coronary angiography, a very conventional sequence, exercise testing to CT angiography to coronary angiography, exercise, and so forth. All these tests, sometimes just going straight to angiography, sometimes straight to CT, sometimes starting, and so forth. There's a very good selection of testing sequences here, embracing most of the imaging modalities we're interested in. Functional imaging, by the way, embraces MR perfusion, SPECT, and stress echo, so all of which are roughly equivalent in terms of diagnostic value, although, of course, proponents of all these tests will tell you different, but the literature suggests they're all pretty much one of them, pretty much similar. So, what the conclusion, the dominant strategy at a threshold of £20,000 per correct diagnosis, that's the threshold the NHS is prepared to tolerate the added cost in achieving a correct diagnosis over a conventional sequence. And for a prevalence of coronary disease less than 30%, so these are patients with really quite a low prevalence of disease, they came up with calcium scoring plus MSCT coronary angiography. And of course that's a group, and remember, less than 10% we're not recommending any test, so this is, if you like, from 10 to 30%. And of course that's the group where you're looking to rule disease out, and so you want to test with the high sensitivity and not many false negative values, so you can reassure patients that they're okay. And here in the middle of the range, a very conventional recommendation for functional imaging, followed by confirmatory invasive angiography as necessary, i.e. in response to a positive test. And here, prevalence of coronary disease 60 to 90%, so that's your the likelihood of disease is really quite high in these patients.